Hello, everyone. Welcome to this session. My name is Dr. Khadija Hafid. I'm a consultant diabetologist based at Rashid Hospital in the United Arab Emirates. And I'm very pleased to be joined by a good friend and a colleague from Dubai Hospital, Dr. Alaaddin Bashir. And together we're going to discuss the cardiometabolic risk assessment, the sort of regional perspectives. Welcome, Dr. Bashir.
Thank you. Thank you very much, Dr. Khadija. It's a pleasure to be with you here today. And I'm Dr. Alaaddin Bashir, a consultant endocrinologist at Dubai Hospital. We're practicing in an area where the cardiovascular risk in our patients is very high. And I believe it's very essential to talk about the cardiometabolic risk in our patients.
Absolutely, absolutely. So let's start off first by thinking about the risk factors. What are the risk factors that are actually driving the cardiometabolic risk in our region?
Well, as you know, Dr. Khadija, it's the cardiovascular risk in our population is extremely high. And that has been driven by many factors. I think the number one, the prevalence of diabetes is very high. A couple of years ago, United Arab Emirates was considered one of the highest countries with prevalence of diabetes. Add to that, diabetes doesn't come alone. It's usually associated with high blood pressure, obesity, and dyslipidemia. A recent study done in our population found that the risk of or the prevalence of obesity is basically obesity and overweight is more than 60% of the population. So you can imagine the risk. Add to that the lifestyle. Yes. We do adopt a very sedentary lifestyle. It's very, very rare, not I would say yes, rare, to find patients who do exercise on daily basis.
Even amongst ourselves as healthcare providers, if you were to ask that question, not many people are doing what we say we should do, right?
Yes, absolutely.
Yeah.
Absolutely. So, and even if we don't usually ask about smoking as well, but I'm sure if we go into detailed history about smoking, I think a significant number of patients will be smokers as well.
So the three main big factors that perhaps we would identify for our context would be obesity, diabetes, physical inactivity, and perhaps smoking as well. These are the kind of the big four that sort of stand out. So there are a number of risk assessment tools that are available out there. How should we adapt these, to suit our population needs?
The risk assessment tools are tools designed to help us to look into patient risks, and based on that risk we decide the treatment for the patient. Currently guideline has moved significantly from just treating diabetes to addressing patient cardiovascular risk and reducing the risk of those patients. Unfortunately, in our region, we did not develop a unified risk calculator for our population. And this is essential because a couple of years ago, a group of cardiologists from Tawam, from Al Ain and Abu Dhabi, they looked into the suitability of risk calculators, the ASCVD, Framingham study, the SCORE study in our population. And they found that these risk calculators actually underestimate the risk of cardiovascular risk in our population. We have seen definitely in our practice patients at the age of 40 presenting with myocardial infarction, where if you look at other ethnicities, they do develop myocardial infarction at a much older age. So recently, in the latest UAE guidelines, we have tried to come with a risk calculator that suits our population, and it's quite simple and practical. I advise all practitioners to try to adopt that risk calculator because we believe it's more accurate looking at our patients.
Right. So I congratulate you for that. I know you've been part of the members of the guideline that have worked so hard to try and get our own sort of UAE-based cardiometabolic risk calculator. So how should clinicians interpret those scores?
Well, it's very essential. As I mentioned previously, we used to say this patient is high risk and there is nothing to do for those patients.
Yeah.
Fortunately enough, over the past, let's say, 10 years, now we have tools to mitigate the risk in those patients.
Yeah.
And it's very essential to risk stratify the patient, and then based on that, you provide him with preventive medications or interventions that reduces their cardiovascular risk and reduces the risk of cardiovascular disease in those patients. So we need to look into patients with diabetes. We should always consider them their high risk unless prove otherwise,
Right.
and then act on that.
Okay. So would you say that there isn't such a thing, is there such a thing as a low risk patient with diabetes?
Low risk diabetes is extremely rare. Diabetes in itself puts you,
Puts
or
you already in
even obesity, diabetes, and even pre-diabetes puts you at a higher risk
a
of
high risk.
cardiovascular
Yeah,
disease.
that is indeed
so
true.
saying mild diabetes, I hear that term quite frequently. Mild diabetes is never mild.
Is never mild.
Even if you're very well controlled, as long as you have diabetes, then you are at an
As long as you've
increased
got dysglycemia,
Yes.
then that already puts you at a higher risk for developing
Absolutely.
those
Absolutely.
other complications.
And I think you're definitely aware, Dr. Khadija, that the risk of complications of diabetes starts even before you know that you have diabetes or dysglycemia.
Absolutely.
We know that at the time of diagnosis, patients with type 2 diabetes, they already have complications of diabetes.
Okay.
So I think early intervention is quite essential
Right.
in those patients.
And what are sort of the gaps that exist in some of the assessment models that we currently have? How can we do better?
I think number one, we should avoid physicians' inertia in risk stratifying patients and giving the right interventions. This is, I think, very essential. Our patients have to be aware that they are at high risk, and we should convey that message in a nice way. They don't need to know.
Yeah.
I mean, when they come to you, they just need to know that they're at higher risk because of their profile.
Right.
But they don't need to know in your risk is 20% in the coming. This is,
Yes.
they might be scared. We need to convey the message in a nice way.
Yeah.
Provide the information without much details that would make them scared. Convince them that they have to take action and they have to adopt a healthier lifestyle. They have to comply with medications.
Yeah.
And fortunately enough, the recent interventions are available do help weight loss, and I think that's something quite desired by all of our patients.
Absolutely.
So they almost all of them would probably agree
I agree
on that.
Yeah. So it's important that whatever risk assessment that we do, it is actually translated and relatable for the patient, because at the end of the day, they need to follow on and take the recommendations that we are putting forth. So coming to prevention now, and yes, we have these risk assessment tools. We know that most of our patients are either in the moderate to high risk categories. What is the role of prevention in trying to reduce the cardiometabolic risk?
Well, as it has always been said, prevention is better than cure. And when we start when I say prevention in diabetes, there are multiple levels in prevention. And
Absolutely.
I think the first level of prevention is and I think all guidelines are going to go that direction in the future, is try to, once you're diagnosed with diabetes, try to get diabetes remission.
Yeah.
And I think that is quite important, because once you get diabetes remission, you are going to almost normalize the risk. So diabetes remission, you achieve it by a healthier lifestyle, by weight loss of more than 15%, and that should be done very early. Once you achieve diabetes remission, you go back. So this is the first level. Diagnosed with diabetes or dysglycemia, get back to
So actually
remission.
screening early.
Absolutely.
You know, as we put it in our guidelines, at age of 30, adults should start, we should start screening our patients early in order to try and catch them
Absolutely, and
as
that's,
early
I
as
think,
possible.
one of the major differences in our guidelines from other guidelines. We
Yes.
have reduced the age
Yes.
of screening. We have to pick the groups of people who are at high risk,
risk.
those with gestational diabetes, those with strong family history of diabetes,
Absolutely.
and those above the age of 35. They have to be screened earlier to detect diabetes, so you can take a step in their prevention.
Okay.
So this is the first step in prevention. The second step is once patients are being diagnosed, they did not achieve remission, I need to risk stratify them. I need to provide them with preventive interventions
Yes.
that would probably help weight loss and help reduce cardiovascular risk as well, namely the SGLT2, the GLP1, that might be very helpful in
To
intervention.
reduce at least the complications
Absolutely.
of the disease.
Yes.
Absolutely.
And it's very essential, Dr. Khadija, to remember that the cost of prevention is quite negligible compared to the management of complications.
Yeah.
So if they reach the level of heart failure, you can see the number of visits, the number of interventions, same for myocardial infarction, same for CKD.
Hospitalization,
And
that costs us
hospitalization.
a lot more than
Absolutely.
having to prevent.
It's more than 10 times the cost of prevention.
Absolutely.
So I think stakeholders should always remember that prevention is much cheaper. When you look initially at the amount you are going to pay, you might consider it a huge amount, but if you look for management of complications, it's much larger amount of money that you need.
In that context, do you think there are regional strategies are required to make sure that we get this strategy right?
I think we can start, number one, by what we just started doing is trying to develop guidelines for our population. You know, Dr. Khadija, that the risk of cardiovascular disease in our patients is much higher than Caucasians, where we see, as I told you previously, at a lower BMI, they develop myocardial infarction, they develop dysglycemia. So, number one, adopting a regional guideline. And second important point is convincing our stakeholders and insurance companies that they have to adopt and follow these guidelines,
Yes.
because that's a way to help physicians prescribe and reduce the risk in this population.
Right.
It's very essential. There were some campaigns that we see it on and off about, healthier lifestyle, trying to make, the like in the parks where you have tracks for walking, tracks for cycling.
Yeah.
I think it might be again expensive, but it's very helpful to help the population adopt a healthier lifestyle. There were some competitions, and I really like these competitions. The 30-30.
The 30-30 challenge that we
Yes.
have every year.
Yes. So if we manage to do that we do it usually in winter because of a good weather,
good
but if we
weather.
manage to do it in summer as well, I think that might be
Indoors,
helpful.
yeah, and there are quite a number of indoor facilities already available that can help with that. Right, so I think to have this collaborative approach between the healthcare providers, with the industry, with the insurance companies, to ensure that we can actually do much better in trying to reduce the burden of cardiovascular disease in patients with diabetes. So to wrap up then, what is the one key message that you would like to give to our audience with regards to cardiometabolic risk assessment and reduction?
The message will be in two parts. The first part, the message is for our patients and the general population that it's very essential to do screening regularly and look at yourself. Even if your physician did not offer you a screening every 6 months to 1 year, you might ask for screening for diabetes and other cardiovascular risk factors. Try to adopt a healthier lifestyle. Walk minimum 30 to 45 minutes on daily basis. Try adjust your exercise level to your needs. You might go for a low intensity, you might need an intermediate or even a higher intensity exercise, and diet is very essential.
Okay.
The second message will be to the practicing physicians that please don't ignore prevention and risk stratification for your patients. Try to provide an earlier intervention, name it whether advices on lifestyle, on diet, or even intervention with medications that mitigate and reduce the cardiovascular risk. And the last advice is for stakeholders and insurance companies. Having a normal A1C doesn't mean that we should not provide our patients with interventions that reduce cardiovascular risk.
Reduce the risk.
Just having dysglycemia is a high risk for our patients.
Thank you very much, Dr. Allah, for all the great insights. I'm sure our audience will agree that we've had a great discussion. Thank you for all the tips that you've given us today. And we look forward to bringing you more episodes in the future.
Inshallah. Thank you very much. Thank you, Dr.
Allah.
Bye.
All right.